Hello, everyone, and welcome. This is the third webinar of 2024 by the Alliance for Pulmonary Hypertension. If this is your first time at one of our webinars, the Alliance is a nonprofit organization registered in Brussels whose mission is the sharing of knowledge and expertise about PH. My name is Rob Platika. I'm from Admedicum, and we've had the pleasure of assisting the Alliance for PH for the last 3 years. Today, our esteemed medical speakers, Dr. Julie Wacker and Professor Maurice Beghetti, will talk about congenital heart disease and PH. Then we're very excited to have Katleen to share the experience of being a mother of a young person living with PH. So as always, questions can be submitted in the chat box wherever you're watching this, and we'll collect those and ask them at the end. The recording and the slides, and we'll make a transcript available on the knowledge sharing platform in the next few weeks. The next webinar is June 18th, and it will be about the genetics of pulmonary hypertension. But without any further delay, let's get to today's topic, which is congenital heart disease and pulmonary hypertension. Dr. Wacker, would you like to take the stage, please?
Yes, thank you very much. I will get my presentation up. Can you see my screen now?
Yes, perfect.
Perfect, excellent. So I'm a pediatric cardiologist at the Geneva University Hospital, and I'm very pleased to talk to you about congenital heart disease and pulmonary hypertension. So as you know, congenital heart disease can occur in about 1 to 100 live births, and about 4 to 28% of patients born with a congenital heart disease will develop pulmonary hypertension. I'm going to talk a bit about physics, so bear with me. I'm going to try to make it very simple. So as you know, a flow through a circuit is the ratio of the difference of pressure in that circuit on the resistance. And if we move that equation around, the delta of pressure is the flow times the resistance. And when we apply that to the pulmonary vasculature, we can see that the mean pulmonary artery pressure minus the left atrial pressure, which is the delta flow across the pulmonary vascular bed, is the pulmonary blood flow times the pulmonary vascular resistance. And we move that around a little bit more, and we have the mean PA pressure, which is necessary for the definition of pulmonary hypertension, which is the pulmonary blood flow times the pulmonary vascular resistance plus the pressure in the left atrium. And this is very important to understand how congenital heart disease can lead to pulmonary hypertension. Of note, we need a cardiac catheterization to measure the pressures, to calculate the flow and estimate the resistance in patients. There are many different ways through which congenital heart disease can lead to pulmonary hypertension, and I will describe them along this presentation. This is a bit of just to give you an idea of the delta pressure across the pulmonary vasculature. We have the mean PA pressure on the left side of those situations and the left atrial pressure on the right side. And you can see that this, in normal situation, there is a slight drop of pressure across the pulmonary vasculature. But you can have sometimes, and we'll see that in the left-sided heart disease, an increase in the LA pressure and just a passive transmission of this increased pressure on the pulmonary arteries. But sometimes, like in hyperkinetic pulmonary hypertension, like in shunts, and we'll see that just in a short while, you can have a left atrial pressure that is not very elevated, but the drop of pressure is very impressive inside the pulmonary vasculature because of the increased resistance. So now we're going to talk about the left to right shunts. So in a shunt, the blood goes always from where the pressure is higher than to where the pressure is lower. And when we talk about pulmonary hypertension associated with congenital heart disease, and this is the case in the classification, in the group 1 of the classification, pulmonary arterial hypertension, we mainly refer to patient with a left to right shunt. And in this situation, you can see that the increase of mean pulmonary artery pressure is mainly due to an increase of pulmonary blood flow because of all this flow that goes from the left to the right and back into the lungs. There are many different types of congenital heart disease that can cause that have a left to right shunt. You have the shunts in atrial septal defect. You can have anomal pulmonary venous drainage, and you can have VSDs, PDAs, and AV canal, truncus arteriosus, and many other complex diseases that are not all highlighted in this slide. Oop. I'm not going to talk about in details about the mechanism by which this increased pulmonary blood flow will lead to pulmonary hypertension in terms of the histological changes, but you can see that at the beginning, you have the arteriolae that are normal, and with the increase of pulmonary blood flow, they start to have some dysfunction and get remodeled until forming a very pathologic plexiform lesion that we can see in other types of pulmonary hypertension. So this is a a continuous process. And when you have a left to right shunt, like let's take a big VSD, in the baseline situation, you have the shunt going from the left ventricle to the right ventricle and into the lungs, which increase the pulmonary blood flow. The arteriolae are normal, but with the increased shunt, you have a medial hypertrophy and you have all the remodeling of all those little arteries in the lungs, and they get very sick. And at some point, the resistance increases so much that the shunt can reverse because the resistance in the lungs increase and is exceeding the resistance in the body. And that's the end stage of a large left to right shunt that has not been treated before. And this is the Eisenmenger syndrome. So depending on the type of your congenital heart disease, you can develop pulmonary hypertension sooner or, and you sorry, if you have a complex congenital heart disease with a shunt in the truncus arteriosus on AV canal, you have a high probability of developing pulmonary hypertension early in life. But if you have like a small ASD, you have very less probability to develop that pulmonary hypertension, and it happens much later in life. And as I said before, it's a continuous process. So, we know that with every left to right shunt, we have opportunity to close the shunt before getting to a zone of no return, after which, if you close the shunt, you can have persistent pulmonary hypertension because your pulmonary vascular disease is so advanced that it becomes irreversible. Or if you leave the shunt open, you can have a Eisenmenger syndrome. It's very tricky to exactly know when you hit that zone of no return. This is, I'm going to pass for the sake of time, but it said the same. Okay. So when you have a left to right shunt, you can have different situations. The most serious end of the spectrum is the Eisenmenger syndrome, where your pulmonary vascular disease is so important that your shunt has reversed. And those patients, you shouldn't close the shunt, but treat them medically. You can have a pulmonary hypertension with a systemic to pulmonary shunt, not yet Eisenmenger. And in this group, you have to find which ones are correctable, and then you can close the shunt. And the ones that are not correctable because the pulmonary vascular disease is advanced, even though not Eisenmenger, you shouldn't close the shunt. And as I've highlighted before, we still need some evidence and some strong data to really know when a shunt is not closable. When you have a small defect, you have a PH that is not believed to be caused by the shunt, and they are treated similarly to idiopathic pulmonary hypertension. And the pulmonary hypertension after a defect correction that persists or recur are also treated medically. I'm not going to go too much into details about the medical treatments that we use, but you know that they are targeting the three distinct pathways: endothelin, nitric oxide, and prostacyclin. So we've talked about left to right shunt and how they provoke pulmonary hypertension. What about left heart disease? So in the left heart disease, you have this time, they belong to the group 2 of the classification. You can have acquired or congenital left-sided heart disease. And in that case, initially, you have the LA pressure that is increased, and that's the main driver of the augmentation of the PA pressure. You can have a lot of different types of left-sided heart disease: a mitral valve anomaly, aortic valve anomaly, a coarctation of the aorta. And in that left-sided heart disease group, when you only have this passive transmission of the post-capillary component, so the LA pressure to the pulmonary artery pressure, you shouldn't treat them with a pulmonary vasodilator. However, there is a proportion of patients that not only, sorry, it doesn't want to advance here. Not only you have an increase in the LA pressure, but you can also have an increase of the pulmonary vascular resistance, because at some point this post-capillary component provokes some changes in the pulmonary arteriole, and you have also a pre-capillary component that coexists with that. And so the patients that have both post-capillary pressure that is increased, but also pulmonary vascular disease with increased pulmonary vascular resistance might benefit from the pulmonary vasodilators, but we still need to have some evidence for that. The mixed mechanism, which is actually the congenital heart disease that are complex and which cause pulmonary hypertension by multiple factor and unclear etiologies, are highlighted here. You can have a segmental pulmonary hypertension, single ventricle, scimitar syndrome. I'll come back to the single ventricle in a short while, but those are very complex congenital heart disease. They cause, or they can be associated with pulmonary hypertension, and we don't have clear guidelines to guide our management. And the last chapter that I wanted to talk briefly about today is the univentricular heart. So in a single ventricle, you can, I'm just going to go slowly on this slide. So in this drawing, you see a normal biventricular circulation. So you have your blood that is deoxygenated, comes back to the right side of the heart, is pumped into the pulmonary artery, gets oxygenated, comes back to the left atrium, and pumped by the left ventricle to deliver the oxygen into the blood and the body. Okay? In a univentricular heart, which are patients that only have one single left or right functioning ventricle, they get all a series of surgery to get to what we call a Fontan physiology, which is actually the redirection of the systemic vein. They are plugged to the pulmonary arteries, so flow is flowing passively from the systemic vein into the lungs, come back to the heart, and then the only pump that those patients have, the ventricle, pumps the oxygenated blood into the body. And you can see that for that physiology to work, you need to have a low pulmonary vascular resistance. Those patients, they often don't fit the definition of pulmonary hypertension. They don't often have a mean PA pressure that's above 25 or 20 now millimeters of mercury, but they can have pulmonary vascular disease. And in those patients that have only one pump, and that have increased pulmonary vascular resistance, which needs to be demonstrated and calculated, those patients might benefit from pulmonary vasodilators. But again, we need more data from studies. So to conclude, we still have a lot of work to do as a medical community, and maybe with the help of a parents association and patients association, we can help shape the future of the research in pulmonary hypertension. But we really need to know if the pulmonary vasodilators can be of use in Fontan patients, if pulmonary vasodilator can be used in those left-sided heart disease that also have a combined pre-capillary component, those that have a pulmonary vascular disease. And we need to better define the operability criteria in patients with an open shunt that comes a bit later than normal to us, to see if we can close the shunt safely, and if those patients can benefit in the longer term from a shunt closure. So I hope this presentation was clear to you. I'm very happy to be here today, and I would be happy to take any question. Thank you.
Thank you very much, Dr. Wacker. That's incredibly interesting and a good starting off point to now pass over to Professor Beghetti, and he'll be talking about the transition from pediatric to adult care in PH. And there we go. Please go ahead.
Thank you, Rob. Hello, everybody. I'm Maurice Beghetti. I'm also in the Pediatric Cardiology University Children's Hospital of Geneva. And my task is to discuss about transition. This is interesting because I'm a quite old person in PH, and transition in pediatric pulmonary hypertension was not really something that was done many years ago because outcome was not so good. But recently I've been asked to discuss about transition, and we will go through transition for congenital heart disease and pulmonary hypertension and show you what it means. Next slide, Rob. So what is transition? Try to define that. Transition is the transfer from a pediatric clinic to an adult clinic. So transition is not just an event, but it should be a process, and I will insist on that over most of the slides. So what do we need? We need physician understanding and education. We need patient education. Clearly, we need parents' education because they were part of the problem for many, many years. And we need hospital staff and administration education. Next. So it's a healthcare priority. There is currently almost no real science behind this process. It's mostly, I would say, experience. There are few papers now that are coming into this literature, but it's quite difficult to run a real study. And I think probably patient association will be very helpful in this process. Next. So congenital heart disease. So let's start with that because it's a mix today. We discuss a mix. Clearly, it's a pioneer specialty in transition plans. There are well-established centers now that practice transition around the world. We have even, I would say, people that are trained in congenital heart disease in adults, and now transition is better. We highlight the need for a team approach. I will insist on that. And the nurse is by far the most important person in this process because parents have usually access to the nurse and they ask a lot of questions. So we will discuss adult congenital heart disease, but we can discuss with or without PH. We'll probably do a sort of combined approach in the next few slides. Next. We can see that in many pediatric diseases, indeed. All the chronic pediatric diseases are now planning transition clinics because congenital heart disease is one, but cystic fibrosis, cancer, sickle cell disease, all these different chronic diseases now need transition because we have made so much progress in pediatrics that these patients now are young adults and they need to have adult care. Next. So, as I told you, survival is improving. And now the question is when and how to transition to avoid problems. And we have to remember that adolescence is a very vulnerable period. Usually you reject your disease, and this is when you start to transition. So that's quite difficult. And the problem, and we'll discuss that, the main problem is loss of follow-up. That means that they are not transitioned, they do not follow the transition, and they will not attend the adult clinic. And this is a big problem, more in congenital heart disease than in pulmonary hypertension. Next. So these are just 3 survival curves that explain why we need transition, is that compared to a 50% survival at 2 years, we are now reaching, even if it's not perfect, 60 to 80%, depending on the disease, of patients that may reach adulthood with this disease. And so they will need to attend an adult clinic because they cannot stay in pediatrics for all life because we need to make space for new patients. So next. So this is a complex slide, but you see that in the middle, you see the specialized center, adult congenital heart disease, called also grown-up congenital heart disease previously. And you see that there are a link with different things. The link with pediatrics on the left, the link with outside hospitals, because sometimes it's not always in the same hospital. I will show you that we're lucky in Geneva that PH clinic are at the same place and CHD clinic are at the same place for adult and pediatrics. That's very helpful, but it's not always. And then you need a lot of specialty services around that. Pulmonary hypertension for clear, because we discussed PH, CHD, but transplantation, genetics, dentistry, and all other organ specialists for this kind of patients. So you need to build a sort of program around your patients. Next. So no gold standard, because I think every center is working differently. So as you have your own practice, you need to build your own transition clinic adapted to your centers, pediatric and adult. For us, a bit easy. Pediatric and adult clinics are in the same hospital, so it's very easy. We have the same chart. We have charts that are transferred from one place to another very easily. And indeed, I'm running the adult and pediatric PH clinic with my adult colleagues. So that's quite easy, but it's not always like that. Next. When is transition successful? So is it when you send the patient to the adult clinic? The answer is definitely no. Next. It is when the patient attends the adult clinic regularly. And that's very important. If the patient is going only once, then you're stuck because you will lose your patient and you cannot follow him up. Next. So why is transition difficult? I like this cartoon. Patients are attached to their pediatrician. Sometimes we know the patients for 15, 16, 17, 18 years. And the pediatrician is also attached to his patients. So both feel very insecure to cut the umbilical cord and at some point say, okay, bye-bye. So it's a very, very long gestation. And sometimes the transfer is not easy for everybody, patient, parents, and doctors. Next. So why is it difficult? I told you, adolescence is a challenging period. Physically, because there are changes, cognitive, and psychological. So you have to imagine adolescents may live that with a lot of difficulties. For children with PAH, having a chronic disease life-limiting, because they know that, there is more overprotection than there is even in congenital heart disease. And so overprotection and insecurity by changing doctors is sometimes difficult. And there is indeed a difference. There is no science behind that, but it's a feeling. It's different if you diagnose a baby and you follow the baby for 15 years and then you transition the patient, than if you diagnose this during adolescence, during this very difficult period, and you transfer rapidly the patient to the adult field. So you have to take that into your mind when you prepare the transition. Next. So there are differences between adults and children. You will see some tables. I will not go into details, but you will have access to these tables when you have access to the YouTube after. So patient-centered care is the key in adults. So the patient is dealing with himself and the doctor. When you do that in pediatrics, it's completely different. There is the caregiver, the parents, other people, and this group needs to be transferred. So in the adults, it's more focused on the disease and you discuss the disease with the patient. In pediatrics, you have to discuss the disease, the family, and the development of the pediatric patients. So it's a bit more difficult. Next. So what helps success? I told you proximity. The pediatrician should be proactive and support transition and not try to impede that. And adolescents who start to come alone at the ped clinics. It's a bit difficult for PH, but for congenital heart disease, sometimes between 16 and 18 years of age, they can start to come alone without the parents, and you can exchange and probably discuss also different things in the absence of the parents. Next. So prior to transition, assess and evaluate adolescent patient cognitive and psychosocial development. screen patient and caregivers for depression and other psychosocial problems, and prepare progressively for transition. Next. So usually I'd start between 12 and 14. I discuss with patients and the family the adult concepts of care. I educate the caregivers, and I provide education materials if I have this available. And I review a lot of different goals with the family and the patients. For example, it's not the same if the patient has a genetic disease or a developmental delay like a trisomy 21. So all these things should be prepared, and you usually 12 to 14 means that you start 4 to 6 years before you transition, because usually you transition at 18s. Next. So these are all the goals. I will not go through the goals, but there are a lot of different things. Administration, medication, self-administration, prophylaxis for endocarditis, school, work plans, all these different things. There is a checklist, and I think the next slide is a sort of checklist, or it will come after. Next. No, first the last clinic visit before transition. So you arrange usually the clinic in the pediatric clinic, but if you can, you should invite the adult doctor. And so it's a conjoined clinic, and the patient see his future doctors and he start to know him. We review the medical summary, we discuss how the initial visit will be done. Sometimes you try to tour the adult clinic so the patient knows where he will go, and he will feel more secure when he will go there. So he knows the new team, and we do that together. Next. So that's the checklist. I think it's good if you can have access to that. That's very helpful. That's a PH checklist for pediatric patient going to adults. So I will not go into detail, but that's very helpful to check all these different things. Next. And you see, this is a summary. So you see if it's ready for transition, if he has passed all the different process, if there is a PH provider, adults, if there is a referral, if the chart has been sent, if he has access already to the phone numbers of the adult doctors, and all so on. And you check everything, and you check with the patient and the family if they have indeed done all these different things and are ready to be transferred. Next. So the first adult clinic is a key. Sometimes I go to the first adult clinic, sometimes not. But if we can do the same, it's better. So for the last clinic in pediatrics, the adult doctor is coming. For the first adult clinic, the pediatric doctor is coming. So the patients feel that it's just a follow-up. Nothing has changed. He's secure and feels comfortable with the new team. And we really find the role and the expectation for the patient, for the parents, and for the adult provider. And with this, the transition is a little bit smoother. Next. So I conclude, and I conclude with everything as I have said during this. It's in a chronic disease, we must improve practice to be sure that you have no loss of follow-up. In congenital heart disease, there are loss of follow-up. I think in pediatric PH, with or without congenital heart disease, usually there is no loss of follow-up because there are a lot of drugs, treatments, and difficulties. So usually it works quite well. But you need to really understand the factors that impact indeed the psychosocial approach of an adolescent and young adult to help him to transition as the best as possible. And then the PH therapies, they need to be adapted. We have indeed a sort of problem that is not a problem, but not all drugs are approved in pediatrics, and they are approved in adults. So sometimes the switch can be a little bit complex, changing the dosage, things like that. Clearly, the two teams should work together so that the patient does not feel that there is uncertainties about how to treat the patient. Next. I think that's probably the last one. So a good transition needs a lot of effort and time. Never underestimate the needs and the problems. You need to make continuous education of patient, staff, and administration, stimulate your hospital to do that, and CHD and PH requires even more attention due to dual disease and sometimes dual clinics. And I'm ready to answer questions if there are any questions.
Thank you very much, Professor Beghetti. That was, very interesting look at a topic that, as you said, is often going neglected. So glad to hear how you and your team are working there in Geneva. That seems very comprehensive there. So now I'm just going to pull up the slides of Katleen, who is the mother of a young man living with PH, and she's going to tell their family's story and journey about how things have gone so far. Katleen, over to you.
Okay, thank you very much. So indeed, and I've been asked to share my story as a mother of a child with pulmonary arterial hypertension. So I'm Katleen, I live in Belgium. I am the proud mother of Vic. Vic has pulmonary hypertension since he was 1.5 and now is 14 years old. He is a bon vivant, a joyful boy with a tremendous amount of motivation and a willpower. His greatest passion is football and everything that has to do with darts. And our story has been different for most patients as we received the diagnosis before symptoms were clearly visible. So let me explain how this happened. That is because Vic was born with a heart defect and called transposition of the great arteries, which means that his two main arteries were incorrectly connected and preventing oxygen-rich blood from reaching his body. Unlike PH, this condition can be cured by an open heart surgery to correct the arteries. A life expectation is good. Vic had this operation when he was 4 days old. There were some serious complications, but after 5 years, 5.5 weeks, Vic was able to leave the hospital in a good condition. Afterward, routine checkups were necessary to ensure that everything remained properly connected. And during a 6-month checkup, an ultrasound relieved an enlargement of the right ventricle, and a heart catheterization was needed for more clarification. And then, unfortunately, I can still hear the cardiologist's words. Your son has a rare, serious disease. It's called pulmonary hypertension, and this time a surgery is not an option. So then many questions, fears, and doubt followed. This was the beginning of an emotional roller coaster and our life with pulmonary hypertension. We knew nothing about it, and through research, but most of all by contacting the Belgian Patient Association, we learned more about this disease. The association still helps us with many questions we have. It's a comfort to know that they will always be there for you. I just recommend you ask them what you want to know rather than searching the internet. But it can be scary for some. Just take your time. When your time is ready to contact them, just do it, because they can support you with not only the medical things, but more practical things like school, insurance, and other things. The feeling that we had when we heard about the PH was, we can't take away its pulmonary hypertension, but we can do everything we want to give him just the best life possible. So, and that is how it goes. Vic, one of his first words was ball, so his passion for the game was evident at an early age. We knew his soccer career would be tough and short, but we didn't hesitate to let him join on a soccer club at the age of 5. It quickly became clear that he was a natural talent to play the game with lots of passion. As the years went by, it became more and more physically demanding. He was forced to be in the goal more often, and at the age of 8, he made the brave but difficult decision to stop playing soccer. We all watched this game together with family and friends, with Vic scoring the last goal of the game, and also the end of his soccer career. That's on the picture that you can see. So there is no need to explain how emotional the moment was, but do we have any regrets about the fact that we let him play in a club? Not at all, because nobody can take those memories away for him, but also for us as a parent. Skiing was also something he really wanted to do. So after consulting his doctor and receiving guidelines, we got the green light to go to this adventure. So once we arrived here, he couldn't ski, and we tried it as well. After one lesson, it became clear that his pulmonary hypertension was limiting the ability to learn. But yeah, it didn't stop us from making the trip. We took the lift skis, Vic skis between mine, and we skied down the mountain together. So I'm so happy we did it, and it was just a beautiful moment for everybody. And just one important thing, despite many limitations, we always try to find a solution to do as many things as possible, even if it seems impossible at first. So the older it gets, more limitations and more aids were needed. It started at 6 with a modified trolley, then the oxygen, a wheelchair, electric bike, and so much more. Over the years, many adjustments have been necessary in school also. Staying home when there was too many infections, take a day of rest now and then, taking longer blocks of classes at home to eventually now a modified class schedule through homeschooling. Um, it means that your child and Vic is becoming more and more isolated. And for me, as a working parent, yeah, you have to make sure that he's taken care of. And in my case, I'm lucky enough to be able to work from home. Although even that is not ideal. Vic is in high school, so then you are supposed to go to school on your own, where less caring is needed for the parents. But for us, this, yeah, it only increased with the years. So there are many additional things that comes with it. Lots of people don't realize this or don't think about it, and does bring frustration sometimes. For Vic, due to his isolation, Vic wanted a dog to accompany homeschooling. I didn't say yes to it right away because I'm more practical thinking, but at the end, it was immediately clear that it was the best decision that we ever did. It is his faithful friend who makes him laugh or comforts when he's going through hard times. And since the summer of last year, his condition has repeatedly decreased. As a result, he was recommended for maximum therapy, starting the Velletri pump medication. Before that, he had been in a clinical trial study for more than a year and a half. In fact, this was his last hope to stabilize or even to improve his condition with medical pills. But unfortunately, with no results, it is likely that he was in the placebo group, which is the group that is not get the real drug. So we had to stop the trial early because we had to maximum increase the therapy. And yeah, why we had to leave the study was because it was a very strict criteria, which makes it very difficult to find suitable candidates. And there was a huge delay on the study. So the time for all patients to get the real drugs, because at a certain point, the study will come to an open study, was delayed until the end of this year instead of last year, which was just too late for my son. So that's the hard reality of a clinical trial and a slap in the face, but you have to go further. So what is one of the difficult things for me as a parent is, in fact, yeah, there is, as I told already, less drugs available for children than for adults. And also clinical trial studies often start later for children. So making a treatment for children even more challenging as for adult patients. One of our biggest fear was the pump medication, and that became a reality. One that has an extremely impact on his life in first place, but also on us as a family. It turned out that we had our last summer vacation last year without a lot of worries, where we enjoyed the pool, the beach, jumping off high rocks into the water, and yeah, just so much more. So we made beautiful memories, but emotionally it was a very hard vacation as well. At the end of September last year, the pump is in use and nothing is the same. His disease was already having a major impact of his quality of life, but with the pump, the impact is even bigger. Um, there is a fear constantly that the catheter will block, that suddenly stopping his medication with potential fatal consequences, and so much more to worry about. Um, for the first few months, I felt like I was more like a caregiver than I was a mom. A lot of your time is spent on medication preparation, providing care. You must think about so many things. For example, if you leave the house, you should always carry spare medication, a spare pump, other medical supplies. When you go on vacation, you need to know where there is a hospital in that country that treats pulmonary hypertension because only they have the expertise. So the medication also has a lot of side effects that can cause a lot of pain and discomfort. With Vic, unfortunately, the side effects are strongly present, like every minute, just living with the line coming from your chest, always connected to a pump is it's very hard. Um, and it's just so many limitations for a child who should be in the prime of his life. And that is something that I find so hard for my son, but also for other children with this disease. And against all odds, the pump medication isn't working for my son. So his condition is still repeatedly worsening. So we are already in the next stage of the process, which is the development of his transplant plan. And it is our biggest fear. So as a parent, it's incredibly hard just to watch a child become sicker and more isolated because of his illness. They are constantly in a battle, both bodily as mentally, against the limitation of pulmonary hypertension. From a young age, they have to consider what they do or don't do, facing the fact that other children are doing what they want to do with lots of energy. Even as a parent, it is confronting because you are so powerless and you can only watch. What does help us as a family is to always have a good laugh, even on the silliest thing, doing something fun as much as possible, watching movies together if he's too tired, and open communication. We decided from the beginning to be honest with Vic about his illness, no matter how hard the answer was. It's his body, his life, and it's not ours. And for us, stress is one of the most important things. Here, taking oxygen is the biggest discussion point where we as a parent want him to take it more often. He also knew that it's important to him, but it's often too much. We then try to come to an agreement about that rather than just saying, you have to do this now. And I always thank him as well when he takes the oxygen because I don't take it for granted. We had many emotional conversations I never thought that I would have to have with my child. He knows that we will answer every question, every honestly. So he has a full trust in us. And yeah, it's very hard for me to see my son just doing less and less. So it's like a chronic mourning. It's a mourning for a loss that never ends. And that is faced by every patient or a parent of a patient. And a well known professor in Belgium, Manu Kersen, said, you accept your child, but not the limitation it has to live with every day. And that's just true. So you constantly have to adapt to changes in your life, people around you, Expect that once you are confronted with this problem, you quickly process and give it a place. We're faced with cruel, throatless, and harsh comments, and we did not receive the support we hoped for, and that can also be from closer friends or family. But we also had new friendship made. So please surround yourself with people that give you energy, listen to you, and are there for you. Also, finding the work-life balance is quite intense. I have a full-time job that I have to combine with the extra care, which is quite difficult. But in the beginning of the pump medication, I just stay home for 4 months, and now I just returned part-time, and I just try to work as much as possible. But because job is also my discretion, and yeah, it's the only place where future is not my biggest enemy. So what is important, in my opinion, is that let your child do what he wants to do, despite your own fears. Just be there if they did too much and you need to care. Try not to say, see, I told you it wasn't a good idea. That's not really the answer that you want to hear from somebody else at that point. So it's easier said than done. I know that from my own experience. I also talk openly and honestly with your child, but above all, listen to your child. Let them decide also when they want to proceed and how they want to proceed. Give your child, and certainly as a teenager, a voice in that treatment, because what I said is their life and their body. And as a parent, we have a different way of thinking because all we want is our child to be with us for as long as possible. I keep myself remind how I was as a teenager and what was my priorities at that time. How would I have react as a teenager? It's not easy to deal with as a mother, but it's still much easier than living with pulmonary hypertension. And also be an advocate for them in difficult conversation with the doctors and fight for their quality of life. Because it happens that doctors only think about the medical aspect and not about the impact of the patient's life and that of a family. Even for me, I thought I had an idea how it is to start with pump medication, but how it is in reality was even more impact than I thought. So I would like to end my presentation by saying the following words to you. It sounds so cliche, but it's really true in our situation. Do not postpone. Life is now. Later it may be too late. And as a parent, don't be too hard on yourself. Give yourself a break as well. If you or your child are having a bad day, let your child just stay home for school and, for example, just go out for a drink or a lunch. And a day like that is going to give you a lot of energy. And most of all, have a good laugh and have fun and make memories. Thank you for listening.
Absolutely wonderful advice, Kathleen, and I want to thank you and your whole family for sharing. And I'm sorry to hear that Vic has had to grow up so fast, and already be faced with some very adult issues while he's still in high school. But yeah, I think you guys are doing absolutely the best you can in your family, and really were able to give us all some perspective on kind of life in general as well. I'll just share a few comments for you, Kathleen, and then we'll get into a few questions. Lots of love and strength for you. I'm impressed. Louise also said it's very good that Vic can try so many things that he enjoys. That's important, and it's nice to see him with his dog, and she has tremendous admiration for you as parents, I think, as we all do. Bizana, who's with the Alliance for PH, is saying a very inspiring presentation. Thank you, Kathleen. Yeah, a lot of thanks for you. So I think while we have some questions too about the medical side of things, bringing it to reality is very important. And yeah, wishing Vic the best in whatever the next steps are to him. For you, Professor Beghetti, we had a question also from Louise. she's heard that the most difficult thing about transition is for both the patient and the parents. The patient is all of a sudden in charge, and the parents are on the sidelines. For both, that can be pretty difficult. Would you have any advice about how both parents and young people living with PH could be better prepared for the transition?
I think this is what I have tried to explain. You need to prepare that in advance. I fully understand, because the parents are involved since a long time, and I think the testimony of Katleen goes exactly this way. I mean, you are involved, and when they become adults, you are still parents. So sometimes it's difficult to give some space also to the patient, and it depends a little bit how it is done. But clearly, this is what the team needs to do to involve the parents as much as possible, but also to give the patient the possibility to start to take care of himself. Because, I mean, if this lasts for a very long time, he will start to have his own life in some ways, depending of the degree of the disease, and you need indeed to make this. But for the parents, as I told you, and you have seen the picture, cutting the umbilical cord when you have a child that has such a difficult disease since many years is extremely difficult. So physicians, nurses, psychologists, psychiatrists, sometimes everybody needs to be involved, but since very early in the disease, not only when everything is going wrong, not only, and I heard that, not only when you decide to go on pump, not only when you decide for transplant. This should be a continuum. I mean, the team should be prepared for that, and the doctor should be very experienced in this disease to organize that in some ways. You see what I mean? If the doctor is very confident, he knows very well the disease, he knows very well the treatment, the discussion with the family, I would not say it's easier, but it's helpful because the family feel confident. But I understand that some parents, and I've seen there is another comment, they would like to go still in the MRI suit and the CT scan suit. In the adult field, it's a bit difficult, unless there is a serious problem, I would say like a trisomy 21 or a developmental delay. But at some point, you have to make the change progressively. You are still involved, but you have to smoothly make the change. Then I would have a lot of comments for what Katleen said, but it's probably too many. The trials, the drugs, the transplant, how this is done, the disease, how to explain that. I mean, I think Katleen has something rare among the rare disease, because transposition of great arteries with PH is extremely rare and has a course that is different from other forms of PH. So this is difficult, but I am working on having drugs for children earlier than later, and I think the authorities start to understand. They start also to understand that families don't like placebo-controlled trials.
Yeah, especially in a rare disease like this,
Yeah.
where time is so important. This is a question for either Dr. Wacker and then maybe Professor Beghetti. Does your center provide professional psychological support for parents or children?
Do you want to answer, Maurice? Or
Yeah.
go?
You can do it.
No.
I can have. We're in the same center.
Yeah,
that's right. Yeah, you mentioned that.
So yes, we do. All our patients with a chronic disease at some point are offered psychological support. It's always proposed or suggested. It's not always taken. I think it's important to re-offer depending on how the situation evolves, because it's also a step, I guess, for parents and children to accept that help. So I think if there's a first a position or not wanting to have this support, I think things can change along the line. So I think it's important, and it's a duty for us to really offer that support. Yeah.
Great,
you
thanks.
must have this support. The problem is, what is the type of support? So it depends on the size also of your clinic. I mean, if you have a big size clinic with a lot of patients, then you may have indeed a specialized psychologist that is to your team. And that's easier. If you are a small clinic, it's more difficult that the hospital delivers you a single person dealing with that. So the adults definitely have that. The pediatric clinics, sometimes they use the usual psychologist or psychiatrist that we have for chronic diseases. They know that. They know how to approach parents, and they know how to help them. So I think it's important. Then we have usually also a specialized psychologist for pre-transplant programs, because that's also a different step.
Mm-hmm. And is your center in contact with PH patient associations there in Switzerland?
So Switzerland is a strange country because we have so many languages. So we had a PH French-speaking patient associations, but it's over because you need people running that, and usually there are patients or parents or something like that. In the German part, there is one, but we are linked with the French one, where there are every year or twice a year meetings for parents and patients association, and that's French speaking. So we are more linked to this part, and then we are linked, as you can see, with PHA. I'm working with PHA, or I worked with the MEA, where we had parents associated to decisions about treatment, trials, all these different things. So yes, we are linked, maybe not as much as we wish, but we are a small part of Switzerland, to tell you the truth.
No, thank you. And Katleen, I wonder, to give you kind of the last question or last comment, sorry to put you on the spot here, but did you have any questions or comments from anything you heard from Dr. Wacker or Professor Beghetti? Anything come to your mind?
No, I was happy to hear how a transition will go, because that is something that I am also worried about already, because I knew of Exactus from when he was born. After we moved to the study clinical trials, we were moved to the adult department as well. So that was the first time for us. And there is a difference between both departments. So it's something that I'm worried about as well, but I try as much as possible just to inform Vic about everything. But it's something, so it was very interesting for me how that is going, because that's something that I already worry about. Because indeed, you are a parent, you always stay a parent, that will never change, but he has to have his own life and his own decision. But that's why we try already with, for us, if Vic now is saying, I would just want to stop the pump medication, then we will follow. Even if we as a parent, we don't want to, that he will stop, that is something that we try to do already. And I think that will make it, I hope, more easy when we have to do the transition.
Great. Yeah, that's true. The transition time is right here.
How old is Vic?
He's now 14.
14. Okay, but they are. I mean, this is not the place to discuss that, but there are new options, new possibilities. I'm sure that your center and the adult center will maybe come with new possibilities.
Yeah, that's what
If you are strong, it seems your son is very strong. So
he is.
we are working to find new solutions.
Yeah, I know.
Great. No, thank you all to our panelists for presenting today. Really enjoyed this webinar. Thanks for coming and speaking on these topics where you're all experts. And to our audience, the next webinar will be on 18th of June on genetics in PH. So we look forward to seeing you back here at that point. And in the meantime, check out the PH knowledge sharing platform for the other webinars and tons of great resources. Thank you, everybody.
Thank you.
Thank you.
Bye, everybody. Thank you.
Bye.